Thank you, Dr. Kojic.
You're welcome, and thank you for inviting me. Always a pleasure. So please, interrupt with questions if you have any. Um, Today's topic is fever in the returning traveler. This is an important topic for us, particularly here, because it seems like the whole world travels through the city at some point. So this is the outline of the talk. I'm going to start with introduction and some history taking, which is in particular to travelers. And of all of the fever-causing infections that can happen in a returning traveler, there are so many of them, but I decided to focus on malaria, dengue, Zika, and chikungunya because those are the most prevalent ones besides diarrheal illnesses that don't necessarily cause fever. I have nothing to disclose. So if we look at the GeoSentinel data from a network of a surveillance network, we have here, and this is from Annals in 2013, the data haven't changed much. When we look at these clinics, to look at what are the most prevalent conditions affecting travelers or ill return travelers, we find that obviously GI problems is the most common at 34%, a third of them. But febrile illnesses comprise up to 23% of them, and then crashes around 20%. And where do they come from? Where are the sick travelers returning from? That is from Asia, mostly Southeastern Asia, 32%, Sub-Saharan Africa, 26%, and those are the most common areas. Of note, we found that about 40% of people do not seek pre-travel, do not have a pre-travel visit prior to travel to get either chemoprophylaxis or vaccines, which is a very high number. So I'm going to talk a little bit about the use of history, location of exposure, and incubation period to limit the differential diagnosis. Because in a returning traveler, it's all about where did the patient come from, where was it, what is the exposure, and the timeline. That's why we stick to such sticklers to timeline in ID, because everything depends on this incubation period. So the first question to ask, are you one of the 40% that did seek pre-travel vaccines and chemoprophylaxis? That can obviously affect your differential diagnosis. And then the illness itself, you have to ask questions about the severity of the current illness, timing, which has to do with the incubation period, and the underlying illness or underlying medical conditions of the patient. That can have a huge impact on your differential diagnosis. Then incubation, as with all infectious processes, the incubation period of the bugs can matter a lot, and that can sort of restrict your differential. And then what is the itinerary? Where was the patient? And you need to get the detailed itinerary because, as I'm going to show you a little later on, even though we know, in general, for example, in this particular country has, let's say, malaria. If it's high up, then there's no malaria because mosquitoes don't like altitude. So the key element, it's a little bit of a busy slide. But, the categories, so obviously you need to look at the geography. What are the countries? Was it urban or rural? Dates of travel, as well as duration of travel, because the longer the stay, the higher they were more likely to be exposed. What kind of a transportation did you utilize in that country? Was it just flying, buses, cars, and so on and so forth? And the accommodation, were you sleeping in a tree house or in a 4-star hotel? Then the second category is the activities and exposure during travel. What were you doing? So sexual activity can matter in some instances. animal exposure, that can matter, tick exposure, mosquitoes, and so on and so forth. Needle and blood exposure, we do see a lot of returning travelers that are in healthcare. There's a lot of healthcare providers traveling and volunteering. So then you need to ask what kind of a clinic, what kind of clientele did you see, and so on and so forth. Food exposures, and then soil and water. A lot of organisms are particular to either salty water or regular stagnant water. And then don't forget the host factors. Obviously, age and sex can matter. Medical problems and past medical history. Don't forget that sometimes travel or some minor infection during travel can set off like a worsening of colitis or Crohn's or other conditions that the patient had already. So this is not for us to go through. This is just a table that I find it useful. This is from the CDC webpage. It's a very useful table in terms of if you have somebody that you're wondering what the patient has, look at the incubation period, incubation time, because there are certain organisms that have a short incubation period, for example, less than 2 weeks. You'll have chikungunya, dengue. Most of the arboviral infections do not go beyond 2 weeks. Acute HIV, influenza, Legionella, and so on and so forth. Then there is the longer or medium incubation period from anywhere from 2 to 6 weeks. Those are some of the arboviral infections. Hep A, Hep B, some forms of schistosomiasis, and then there's a long incubation period. This is very helpful to sort of frame what are you looking at, what are you thinking about. So this is on the CDC webpage. It's easy to find it. It's cdc.gov, travel, and there are a lot of good sort of go-to tables. This is depicting the incubation period more and more. It's the same, and it's the same information, just in a more visual. As you can see, malaria, there are some forms of malaria that can happen months and months later, like Plasmodium malariae. Plasmodium falciparum tends to be down here. We'll go more over that. Rabies is one of the longer ones. And then TB also, primary TB, that tends to be a reactivation typically. And Hep B also has a long. The other ones are mostly you're dealing, in a returning traveler, you're mostly dealing with less than 2 weeks. So what are the common causes by geography? That's another table from the CDC. You don't have to, this is not something to remember. Just know that it's a good resource to have. They have, if the patient is returning from the Caribbean, the most common ones that are causing febrile illnesses are chikungunya, dengue, malaria, and Zika, which are the ones that we're going to talk about. But there are others, particularly histoplasmosis, leptospirosis, and a lot of others. And then Central America, again, pretty much the same. South America, South Central Asia, Southeast Asia, and Sub-Saharan Africa. So all of these sort of list the most common one. It's helpful for you to zone in on what to look for. Then you may not need to focus on others. So let's talk a little bit about malaria. Obviously, it's a huge problem. We don't see that much here, although we did have a patient here, I don't know who was involved this week with malaria here at this hospital. More than 3 billion people actually live in areas at risk for malaria transmission. So the impact of this is huge. Having said that, there are about 35 countries that account for 98% of the global malaria deaths, and those are mostly in Sub-Saharan Africa and Asia. 89% of malaria deaths worldwide occur in Africa, and malaria is the 5th cause of death from infectious disease worldwide. right after respiratory infections, HIV/AIDS, diarrheal illnesses, and TB. However, in Africa, it is the second leading cause of death from infectious diseases. So it's a huge problem, particularly amongst children and older. So what is it? It's a protozoan parasite transmitted to human RBC, red blood cells by the mosquito. There are several types. The most common ones are falciparum, vivax, and ovale, followed by malaria. There's also another type called Knowlesi. I don't know if you're familiar with that. That is a it's an emerging pathogen, mostly in primates, but now we're seeing them in humans also. But what you should know is falciparum. That's the one that you should definitely know. The Plasmodium falciparum can result in recrudescence when the parasites are incompletely eliminated and infection recurs weeks or months later. So we'll talk about the incubation period, which is again the most important factor to look at. And I'm bringing this up as the epidemiology. If you look at the red areas, that's where you have malaria transmission throughout. But in the other areas, in the yellow areas, it's very patchy. For example, in South Africa, there's malaria transmission only up in Kruger National Park, taking that as an example. So if the patient was traveling to Johannesburg, you don't have to think about malaria. The same applies to countries in South America. They're very patchy, and it has to do with where the mosquito lives and where it thrives. In higher altitude areas, the mosquito doesn't live, and if the patient was only in high altitude, malaria should go lower on your list. Same applies to countries in Southeast Asia. Very patchy. Thailand is an example. You can see it in Chiang Mai up in northeast, but nothing in Bangkok and the southern parts, and Vietnam is another one. So my message to you, if you're thinking about malaria, go to these websites and look exactly, get a very detailed itinerary history, and go and look at exactly where you are at risk for malaria transmission. We love these cycles in ID. So how do you get it? The mosquito feeds on the skin and injects these sporocytes, which go directly to the liver and infect the hepatocytes, where they mature into scitons, which rupture, releasing a lot of these merozoites into the bloodstream. And it's the merozoites that infect the red blood cells. Which sets off this cycle, and it's the release of these merozoites that causes the fever. So that's why patients with malaria typically tend to get fevers off and on. It comes and goes. And the timing between the peaks of fever differs between the different types of malaria. These then are released into gametocytes within the bloodstreams, and another mosquito feeding on the patient will then get infected, and so on and so forth. On this slide, you will also see which anti-malarial drugs work at which stage. And the only thing to remember is that the Malarone, which is a provocaine proguanil, and primaquine, that will work on the hepatic stages. So there are two types of falciparum that can live in the liver and cause infections later on, and that's vivax and ovale. Vivax more so than ovale, but falciparum does not do that. So what are the clinical features? Nothing that you don't know. Just have to go through them here. Remember that it takes a week. The incubation period, again, for falciparum is a week. So the patient is asymptomatic from the time of exposure up until a week later, up and sometimes even 10 days later. And for falciparum, Vivax, and Ovali, it's about a week, sometimes up to 2 weeks, even 17 days. But the Plasmodium malariae has a much, much longer incubation period and is a much, much milder disease. You're much less likely to see those patients in the hospital. That would be more in clinics. The initial symptoms are non-specific, and they can actually present with just like a viral illness. Our patient, for example, he mostly had a GI problem. He just was vomiting, had a nausea, right? Uh, fever was not a prominent feature. It was literally GI. So they can present with any kind of presentation. Most often a viral illness where they then ultimately develop fevers, headache, fatigue, joint pains, muscle aches, nausea, and vomiting. GI symptoms are often quite prominent. The classic malaria paroxysms of chills and rigors, we called classic, but we don't necessarily always see it that way. They get chills and rigors followed by fever spikes with sweating and fatigue. And as I mentioned before, these paroxysms coincide with the rupture of blood schistons and the release of the byproduct into the bloodstream and the cytokines associated with that. This can occur in a 48-hour cycle or even longer with depending on which type. And this is the reason why you need to repeat the test. If you get one smear that's negative, repeat it next day and even get a third set if it's negative. If you have a patient that has been traveling and he gets fevers and sort of fever paroxysms, then think about malaria, put that higher on your list. Typhoid fever tends to be, for example, more of a steady fever. Severe malaria is something that is very worrisome. It's the fatality rate, even with treatment, I'm just going to point that out here, is up to 20%. So be on the lookout. These patients need to be monitored, and I often say, even though when they come in, one smear is never enough. You need to get the burden of disease and on the first smear, and then you need a follow-up. If it's going up rapidly, that's a patient that you need to monitor, especially because that means that the burden may be much higher than you anticipate. What are the clinical features of severe malaria? That is impaired consciousness or even coma. Convulsions can happen, seizures, they get respiratory compromise pretty fast, circulatory collapse with shock and systolic pressure less than 70%, jaundice, hemoglobinuria, spontaneous bleeding even, and acute renal failure. So sort of like if you're starting to see any evidence of end organ failure, that you need to call the unit, that those patients need very close monitoring. The pathophysiology, we often talk about severe malaria being either, some people say 5% smear, others say 10%. But in reality, it's also not just the absolute percentage, is also how fast is that percentage changing? Is it going up really fast? That can be classified as severe malaria also. And this is just the pathophysiology. You get sequestrations of these infected erythrocytes. You end up getting small infarct, capillary leakage, and organ dysfunction. And again, 10 to 20% fatality, even with treatment. This is just a little bit of a summary. Falciparum is the one that you need to be worried about, and it's the one that tend to end up in the hospital, actually. Vivax and Ovali, what you need to remember that those are the two types that can give you a hepatic infection and recur a month later, if not treated with the appropriate anti-malarials. Vivax and Ovali are more likely to cause uncomplicated, so you would possibly see that more in the outpatient setting than inpatient. Vivax is the one that tends to cause relapse, more so than Ovali. And malaria is a little bit, a very different kind of a malaria, or falciparum malaria. It's usually uncomplicated, very, very low level of parasitemia, and these people do not end up in the hospital. Diagnosis, as you know, it's the thick smear. That's the standard diagnosis here in this country. In Africa, and I brought this just to point it out to you, there are several rapid diagnostics that have been now approved and are used. This one is quite common. It actually tests for falciparum versus non-falciparum. It doesn't really give you any other distinction. But because that's what we do need to know. If it's falciparum, we need to be more on, patient needs to be more, needs to be admitted. And for falciparum, the sensitivity and specificity of these rapid tests is up to 95 and 94%. 95% specific and 94%. These are really good tests. Diagnosis and treatment, again, these are from the CDC guidelines, which is a combined recommendation from WHO and the CDC. You obviously take the history. If you still think that it's malaria, you do the thick and thin smears. Again, you need to repeat them if the first one is negative. If it's positive, you obviously check the parasitemia and treat accordingly. If negative, you repeat it every 12 to 24 hours, at least 3 times. And then if it's still negative, then you go on, you move on to your other differential diagnosis. Again, this is just a slide to show you that I'm going to start up at the top here. You have to decide whether you're dealing with severe malaria or not. So as I mentioned before, severe malaria, is the parasite burden high or is it going up rapidly? And do you have end organ damage? If you have any of those, that's severe malaria. That's an admission and IV treatment. If it's an uncomplicated malaria, which is what we actually see most of the time, again, go to the CDC and look at where did the patient come from? Are you at risk for falciparum or non-falciparum? On the smear, they should be able to tell you if it's falciparum or non-falciparum. If it is falciparum, that's where you look at these right-sided of the slide. You look, did the patient come from a chloroquine-sensitive area or not? I'll give you a rule of thumb, is there are only really 2 areas in the world that have a chloroquine-sensitive falciparum. It's the Arabic Peninsula and it's Central America. So use that. And then there are some nuances with it, but that, in general, chloroquine works in those areas only, and all the rest of the world, so if the patient comes back, he was on chloroquine as a chemoprophylaxis, but came back from Africa, you will know that it didn't work. So you try and discern whether it's whether the patient is from a chloroquine sensitive or resistant area, and you decide on treatment. So Malarone actually works for a lot. If you look at this slide, Malarone works for most of these organisms, and it's an easy treatment to give. It's 4 tablets daily for 3 days, and that's the treatment. Malaria and Ovali are usually chloroquine sensitive, so you can use that for that if you know for a fact that that's the organism. Vivax, I wouldn't, that sort of can be a hit and miss, so I would recommend you use the Malarone for that. And there's this no lessy, which is an emerging pathogen, which we know not that much about, actually. Any questions on malaria? So that's probably the one that you see the most here, so from all the travelers. Dengue. Dengue is another infection caused by mosquito bites, the Aedes mosquito. Dengue, the incubation period is, again, short term. It's usually about 4 to 7 days after the mosquito bites. That's when you start to get symptomatic. And it can last from 3 to 10 days. There are some rare reports of transmission from organ transplant or blood transfusions, as with all of these both tick and mosquito organisms, but those are rare and far between. And there is also evidence of vertical transmission, but usually it is an exposure to an infected mosquito. Epidemics can occur, and they occur, I would say, on a yearly basis in some parts of the world. And that happens when you have a concurrence of large numbers of vector mosquitoes, a large number of people with no immunity to it, and no immunity to one of the 4 types of dengue that are out there, and the opportunity for contact. In other words, if you were in a highly endemic area. So dengue is actually, the history is interesting. Interesting. It originated in monkeys, and then eventually went over to humans. It used to be that it was a minor, very geographically restricted disease up until the mid-20th century. After World War II, it's thought that the war played a critical or a crucial role in disseminating dengue. And the first documented infection outside of its origin was in the 50s, and there were epidemics in both the Philippines and Thailand. And by 1981, we were seeing a lot of these cases in the Caribbean and Latin America. So you think about it, it was just really in the span of 50 years that the spread of these infections. Now, with all the travel that we're seeing, we're going to be seeing a lot more of these. So what's the epidemiology? About 40% today's day and age of the world's population is now at risk of dengue, so it's no longer very restricted. The WHO currently estimates there may be 50 to 100 million dengue infections worldwide every year, and it is endemic in more than 100 countries in Africa, Americas, Eastern Mediterranean, Southeast Asia, and Western Pacific, so pretty much everywhere except Northern America. So we have a lot of cases, and in 2010, about 1.6 million cases of dengue were reported in the Americas alone, with 49,000 cases of severe dengue. So that's definitely. How many of you have seen cases of dengue? See, a lot of you. So again, while it used to be geographically restricted, it is now much more widespread, as you can see in Africa, South America, Southeastern Asia, India, very prevalent. So the incubation period, again, short incubation period, 3 to 14 days. Many patients are asymptomatic, and we've sometimes even found it incidentally. But they end up getting fevers and a rash. So those 2 symptoms are quite. And another thing is they talk about a retroorbital headache, severe headache. I've never seen a dengue patient that has not had a severe headache. But there's the classic dengue, where you have the fever, this retroorbital headache, musculoskeletal pain, and this rash, which can be manifest in different forms. Leukopenia, thrombocytopenia. And the diagnosis, unfortunately, is mostly clinical, but you can send the serology. There is a PCR also, but serology is the way to diagnose dengue. The rash can be quite subtle, just some small papules on the extremity, so you do need to do a very thorough exam. What time is it? Oh, we have a thorough exam. And the danger of dengue is the hemorrhagic fever that can be associated. That tends to happen on a repeat exposure to dengue, not the initial one. has to do with the immune system, and dengue shock syndrome. And this is an immunopathologic disease that is usually seen, as I said, in a secondary infection in most of the cases, with certain serotypes, and you get fever. That's where you get the positive tourniquet sign, which you will see on tests. They have thrombocytopenia, and then they tend to have hemoconcentration. And this is a nice image here, or graph. And what I want to point out is that the febrile illness, which you start off with in about a week after exposure, you get high fevers, but as the fever starts to subside, that's when you get the critical illness. So even if the patient is becoming a febrile, he's not out of the danger zone. That's where they get the shock and the bleeding. And then there's the recovery phase. Again, the period of effervescence correlates with the onset of hemorrhagic complication. And then dengue shock syndrome, obviously, that, as the word implies, it's just the hemorrhagic fever plus shock. I'm not going to go over this, just keep in mind, I'm just going to tell you that if you have a patient with dengue and you see a certain warning signs, that's where you need to worry. Those warning signs are abdominal pain and tenderness, persistent vomitings, again, persistent GI symptoms, fluid accumulation, mucosal bleeding, obviously, lethargy and restlessness. So that means that that's another warning sign. If the liver is getting enlarged, and then the increase in hematocrit concurrent with a rapid decrease in platelets. So thrombocytopenia and hemoconcentration, that's a warning sign. You know, there's a lot of overlap between chikungunya and dengue, and it can be quite confusing. And the problem with both of those, that when you're dealing with the acute phase, it's a clinical diagnosis, because the diagnosis is serology, and you won't get that for another 4 or 5 days or even longer. They have many common clinical symptoms and areas of geographic distribution that come from the same areas. Difficult to distinguish, but there are a few rules, and I'll just go to the next slide. The one thing that with dengue, you tend to get the restlessness and pain behind eyes. That tends to be more of a lean towards dengue if you have that. And chikungunya, mostly joints. So I was going to do chikungunya first, but okay, Zika first. The Zika is sort of, it was a big deal a few years ago. I'm sure you all remember that. Zika virus, that's another virus transmitted by mosquitoes. They tend to breed in water-holding containers. They are both day and nighttime biters, the vector, and feeds both indoors and outdoors. So therefore, if your patient is going to a Zika endemic country, netting is quite important in addition to other mosquito repellents. You can get infected with Zika, obviously, through mosquito bite, but also a vertical transmission from a pregnant mother to a fetus, and also sexual transmission. And that, I don't know if you remember, a few years ago, the recommendation kept changing. It was, you know, they couldn't have sex if a male was coming from an endemic area. We were recommending first abstaining for 3 months, and then it ended up being an abstinence for up to a year, which is where it's at now. Condoms do work. So what's the situation with Zika in the US? This is from the CDC, again, as of December 5th. It's not a lot. It seems the epidemic seems to have subsided, fortunately. There were 17 Zika virus disease cases reported. Of those, 16 are in return travelers, and only 1 with a lab exposure. when we look at the U.S. territories to include Puerto Rico and so on, higher numbers, but again, mostly in people that were exposed in endemic areas. So this is an imported infection. Clinical presentations, again, most people with Zika are asymptomatic. The big deal with Zika infection is the fetal abnormalities. Characteristical clinical findings are fever and a rash. They all have febrile rashes, arthralgia and conjunctivitis, myalgias, headaches, and the Zika clinical illness is usually mild, and the symptoms can last for several days, sometimes up to a week, but it's a short duration of symptoms and usually mild. Severe disease requiring hospitalization is very uncommon. You will see this, you're more likely to see this in your clinics than here. However, there are increasing reports that we're seeing now with some complications like Guillain-Barré following Zika virus infection. This is the problem with Zika. It's the infection during pregnancy, particularly the first trimester of pregnancy. That's the highest risk. And it can cause all sorts of neurological complications. You're most familiar with the microcephaly that it causes, but there's also other milder neurological problems like vision and hearing problems, limb moving, feeding in babies, and seizures. So how do you diagnose it? There's a long list of differential diagnoses. Obviously, a febrile illness with a rash and diffuse myalgia. There's a lot of viruses that can cause that, and other infectious etiologies. The diagnosis is, again, just like with chikungunya and dengue, this is a clinical diagnosis. And, but you can send the virus-specific immunoglobulins and or serology, so serology, just like the other one. It is a reportable disease. It's not on us as physicians. It's usually the lab, but just keep that in mind. It is a reportable disease because it's an arboviral disease. Usually it's the lab that does that directly to the Department of Health, which then sends it over. But it's always good to make sure that that happens. There was an advisory that came out just December 12th with because this epidemic seems to be going down or subsiding, we are no longer, the advisory is basically saying that dengue is currently causing the large outbreaks in many parts of the world, with low to no Zika virus transmission being reported globally. And because of these changing epidemiology, Zika testing guidelines has been updated as of December, and we are no longer recommending Zika IgM testing for symptomatic persons if they're not pregnant. So non-pregnant, healthy people, if you think it's Zika, it's fine, you don't have to test for it. So we do not routinely recommend Zika testing for asymptomatic pregnant persons living or traveling in the U.S. or territories. However, testing should still be done in the patients that were traveling in a Zika endemic area, and if they're coming from a Zika endemic area. So pregnant travelers tested, otherwise don't need to test. Congenital Zika testing hasn't changed. All the babies should be tested if the mother was exposed or even the father. So we're going to end up on chikungunya. It's an alpha virus, yet another mosquito-transmitted viral infection. We have 3 minutes, so let me just go back, jump to this last bullet here, because it's the word chikungunya means that which bends up or stoop walk. And if you've seen chikungunya, the one symptom that these people people have is severe arthralgia. They cannot move. They can hardly move their arms, backs on, and many people will tell you, I think it's chikungunya because it typically mostly affects joints. Where do we find it? These are the countries and territories where chikungunya has now been reported. And this is again as of last year. It used to be this, I change this slide every year because there's always more and more green spaces coming up. I want to point out here France and Italy. That is now officially an area where we've had transmission of chikungunya. Otherwise, and all over the United States also. Remember, this is from surveillance data, so it's just reporting where it's been reported. It doesn't tell you where it came from. What are the clinical manifestations? Again, fever and malaise, incubation period only 2 to 4 days, with a range of up to 2 weeks. So beyond 2 weeks, you don't have to think about these organisms that we've been talking about here today. Fevers, and then the polyarthralgia tends to begin 2 to 5 days after the onset of fevers. So they have a febrile illness, then they get the severe joint involvement. You see skin manifestations up to 75% of patients, but not everyone. Note that not everybody gets a rash. Headache, myalgia, so non-specific symptoms, again, GI symptoms. And on lab, you'll find lymphopenia, thrombocytopenia, and elevated LFTs, sort of like with rickettsia. I just want to point out that we're seeing more and more that there are some persistent clinical manifestations that you can see. So in particular, you can set off a rheumatological problem that can last for months and years. They can have arthritis, arthralgia of almost any joint, and that can be persistent for months. So it's worth asking, where did you travel even last year? Is there a risk for that? You can even get Raynaud's phenomenon up to 2 to 3 months after infection, and that has been described in up to 20% of people. The duration of these consequences can be variable. I'm going to skip this slide. Just keep in mind that you can actually have severe complications, particularly in older people that get infected with chikungunya. Even respiratory failure, cardiovascular decompensation, and myocarditis has been described. Meningoencephalitis and Guillain-Barré is the most common neurological long-term complication, and we still it's rare, but it's there. Probably going to be seeing more and more of that. Diagnosis is by serology, and treatment is supportive care. There's currently no antiviral agent that is known to work. So mosquito bite prevention is the most important message that you can give your patients that are going to travel to any of these countries. And that is, so DEET is at least 28% for skin, and then permethrin for clothing. It's something that you treat clothing with, and not only is it a good mosquito repellent, it also kills ticks. So permethrin for clothing, DEET for skin. There is a very promising vaccine in development for chikungunya, so hopefully in the coming talks we will have that. It's exactly 1:02.
People at Dukes were kicked out at 1 p.m., but do you guys have any questions here? So I thought if we can take 5 minutes to sort of like exploit one of the strongest things that we have in our program, we should. I don't know what you think about this, Dr. Kojic, but I think we have people here from several countries in the world.
So I know, it's amazing.
Yeah,
amazing.
So what if we say in 15 seconds, what should you think about if someone is coming with fever from your country? Right? Right. So I'm going to start. If you get someone with fever from Cuba, your number one should think about just common cold and things of that sort. Those are more prevalent. Dengue and chikungunya are all over Cuba, so you should definitely think about dengue, and we have dengue all year long. You should also think about some other rare diseases that can present, including leptospirosis, which we see quite often. And that's pretty much. You should never think about malaria or typhoid in Cuba. We don't have that. All right. So, Marcelo.
Yeah. El Salvador, dengue, chikungunya are the two big ones. We have some malaria, and we do have typhoid fever. In fact, I did have typhoid fever. I did, yeah.
Valeria from Ecuador, we have all of those, every single one, and I would add tuberculosis.
But Ecuador, isn't that an interesting country? Isn't the middle of the country like very high up?
Yeah, it's just the equator though, so
Yeah.
I'm from the coast, so most